Actually, my maternity class. Whoops. One more. Do this quick and we'll do that. There we go. Versatility. That I can say. Specialized lymphocyte with its own antigen sensitivity is grouped with others like it. So in a way, that's really good. You have a group of lymphocytes together that can divide up really rapidly in the presence of an antigen. So it's good to think that these lymphocytes are in storage. It means that the body's not putting in a lot of effort to keep a whole bunch of them functional, but it has the few that are in storage and they can quickly reproduce. So it's kind of conserving some body energy. So the bottom part of this, for the students that are at home, if you can't read it, does not have to produce large numbers of each kind. Specialized lymphocyte until a specific antigen is present, and that's what that bottom part says. Next time I do the PowerPoints, I will do them this way. I have to read them up. Yeah, my hands are starting to get cold too. I've got a sweater today. I actually went out and bought a sweater specifically to come up here. Cold last time.
It's cooler here than it is in the cafe.
Oh, really?
Yeah. It was warm over there.
Yeah. Memory refers to the body's ability to provide protection from pathogen that it was previously exposed to, and we've already discussed that in the fact that the measles virus, right? My body remembers how to build the antibody that is specifically just for that measles virus. The problem with the flu virus injections each year, your body may remember a specific type of flu that you had, like a H1N1 that you may have had. It will have the antibodies for that. But the flu virus changes every year usually. It changes in some molecules, just enough so that you won't have the antibodies to it. Also, viruses mutate, like flu viruses especially can mutate into just different forms your body doesn't recognize, so it doesn't have the antibodies. So every year they come out with another flu vaccine, and they usually do it by studying the flu viruses that are present in China and the high population areas, Indonesia and those areas, and anticipating that that's going to circumvent the world, and that particular virus is going to show up. That's how they determine how they put together their vaccine for that year. The problem is with flu viruses, then it's kind of a hit or miss. Like you may not get that particular flu going around the world, and the flu vaccine is not working for that particular virus. So there's some pitfalls with the flu vaccine. So that's why it doesn't work sometimes too.
You might get the one that they might not in your body when you're waiting for it.
That's right. You may pick up one that is prevalent last year and has mutated or something like that. So it is a difficult process to invent or to create these flu vaccines, and that's why they're ineffective. Tolerance. When the body contains antigens that the immune system doesn't respond to, that it develops a tolerance to. And this is important for your kidney transplants or your heart transplants, so that they won't reject that. So they use something to suppress the production of antibodies. So you usually take suppressants when you have an organ transplant. The other thing you can think of too is antigens. People that get the injections for allergies. They're allergy shots, what they normally call them. All that allergy shots are is they're introducing the allergen, the antigen, to the person in small doses. So eventually their body does kind of adjust to it and develops a tolerance to it. It's really tricky. I used to do them for Westside Medical, West Bay. Did the allergy shots, and boy, they're scary to do. Because if you give too much, you may give that person a severe reaction. If you give too little, then you don't get the response that you're trying to get with the body becoming used to them. That is a bit tricky, though. And I know one of the doctor's staff members in Kelowna gave an allergy desensitization to a person who was allergic to bees, and that unfortunately that person died because it was just too much, and they had an anaphylactic shock. So giving allergy shots can be really risky, especially to the bee stings and wasp stings. They seem for some reason very difficult to control the amount you're giving. That's scary. It is scary, and I was fortunate enough. I did have one person who's getting one for wasps, but I was really careful. We need those. Anyway, children and immunity. Oftentimes, maternal or fetal antibodies can only provide partial protection. And that's important when we talk about rubella, because I know that rubella or German measles can cause deformities in the fetus. Even though the mother may have some antibodies, the baby will respond by having issues with deformities. But the other thing, too, is that's why a lot of women will get their antibody titer done to rubella early in their pregnancy to make sure they have those antibodies. They don't normally give you the immunization during your pregnancy, but after your pregnancy, for subsequent babies that you may have, they will give you an immunization. It's low, you don't have enough antibodies. I was surprised at this when I read it, that children are on an average are exposed to one new antigen every 6 weeks. That's a lot, really, for their little bodies to cope with and to produce antibodies too. There's quite a controversy about the way they give. Do you get your kids immunized, or your wee baby coming up? Yeah. There's quite a controversy now about the way they're giving the vaccinations. Is that they're giving a lot of different diseases at the same time. So you will be getting, say, you're getting Haemophilus influenza and mumps and measles. There's one, I think there's an 18 months, if I'm correct, they're giving 6 different types of vaccines for these illnesses. And whether the baby's body is able to build up antibodies to all these 6 different types is a question. My little niece had her immunizations, and she got really ill afterwards. And the mom says, I'm going to still immunize her, but I'm going to do it, 1 or 2 at a time rather than 6 at a time. So she got quite ill, and she didn't respond very well for several hours after she was given it. So that really frightened her. So now she's changed her mind. But it is a lot to expect a child to build up antibodies to diphtheria, tetanus, pertussis, mumps, measles, rubella, all at the same time. It's a hard one. I think it's harder. Alberta has a different immunization schedule than we do here in British Columbia, and it's a little bit softer. It's not as many at one time. But when you get your baby immunized, ask. Yeah, well, ask. Because, there's some questions about it. Oops, it jumped. So make sure that autoimmune diseases. Type 1 diabetes, rheumatoid arthritis. Unfortunately, our immune system, mine being one of them, has created antibodies to our own tissues. instead of me creating antibodies to, in my case, Hep B vaccine, I created antibodies to my own beta cells. So I destroyed my beta cells, and I was unable to produce insulin anymore. There's a lot of controversy about that too. Your Hep B vaccines, there's been quite a few studies done, and they can cause diabetes type 1. So yeah, it's scary. I had actually my 3 regular shots, and everything was fine, but I didn't have any titers do that. So I didn't have any antibodies. So they gave me a booster and another booster, and 6 weeks after my second booster, I developed diabetes. So there was a and at the time, there was 5 other nurses in the National Hospital that also had no titers. We had no antibodies. 3 out of the 5 developed diabetes. The other 2 borderline have issues with low high blood sugars. So there's some questions about that. So yeah, it's kind of scary. The company that prepared the vaccine for when we took it and in the 1980s is no longer making vaccines anymore. So there's some questions. Scary stuff. Think about it. Don't let them give you a booster. Take your 3, but don't let them give you a booster. Yeah. That came out this year on BCTV that they don't want to give you anymore because there's some issues. So yeah, I'm all for immunizations, but with caution.
How old were you when you were diagnosed?
36. Well, first of all, I thought I had type 2 because it makes more sense to have type 2 at that age, right? And I wasn't overweight, so there was a lot of questions and loss. But like I said, diabetes is starvation because your cells aren't getting any sugar, so you're actually starving. So that's why I lost so much weight. But anyway, yeah, so it was unusual to see somebody develop type 1 that late in life. Yeah, anyway, that's a lot of stories. But I did for stem cell transplant in Germany, which actually helped. It decreased my need for insulin by about 30%. So it did make a difference. There's no cure with doing stem cell transplants. There could be a cure if you used fetal stem cells, but these were autologous, which means they were stem cells. So yeah, I had that done, which was successful, and I would go back again in a heartbeat and have the second one done. But it's private, so it's like $20,000. So it's expensive. So I don't have $20,000 floating around right now. That was an inheritance that my father had passed on. I used the money. But yeah, I would do it again because I think it would be much more simple. Anyway. Okay. So there is a lot of destruction of the body's own tissues, healthy tissues, where you do have autoimmune disease. Immunodeficiency, like AIDS and HIV, immunosuppressive drugs. People would be given the immunosuppressives for kidney transplant, heart transplant, that type of thing. And your chemotherapy, of course, suppresses your immune system. So that's why you get your HIV and AIDS patients with secondary infections overimposed on top of the HIV, like the sarcomas and pneumonias, that type of thing, that are rare in regular people who have a functioning immune system. They're quite rare diseases that they get, so they can't fight them off. Yes?
It's not really like HIV and AIDS actually.
It's what they do to you. Okay, it's not the AIDS itself. It's the lack of immunity that you develop. Right? So then, like I say, you can get some very bizarre illnesses that, like fungal infections, where you and I, healthy people who don't have AIDS or have immune problems, wouldn't ever get a fungal infection in our lungs. So they can get lots of very unusual infections. That's what kills them. Yeah. They've made huge strides with AIDS and HIV drugs that they're using right now. I mean, it's a cocktail of drugs, but still, it's working. There's a lot more people surviving and living better lives than there was before. Pardon me?
I had a cousin who has it, and she's been really
Fine.
She has her sickness and whatnot, right? She's so sick that when her kids were 13 and 12, she made them learn her drug because if anything bad happened, she wouldn't get to the hospital.
Great.
She's still doing fine.
But I think it's very expensive, the drugs that they have to use to help their immune system are extremely expensive. So I think that's hard on people too, is the cost of everything. That makes it bad. So we're talking about stress and immunity right now, and we all know that when we get stressed out, we get colds. I do, anyway. I get colds. So the HTCH released from the anterior pituitary leads to a release of cortisol by the adrenal cortex. And that's when they say that your serum cortisols are high, often. And that really affects me as well. If I'm stressed, my cortisol level will be high and my blood sugar will go way up. So stress is really does affect you badly. So you try to keep your stress down to a minimum if you can. I know it's hard in this day and age, especially when you're going to school and you're working and you're paying bills and all that other stuff. It's very difficult. But it is important if you can try to keep your stress levels down a bit. Or do things that help you relax, like exercise. Exercise is very important for the immune system. It'll actually support it. And your gap is in here as well. We studied that already. Aging and immunity. Well, the immune system, of course, becomes less effective because the cells are slowing down and they're not producing as many cells as they were. Danielle's cells are declining. Yeah, no. Or killer cells. So you just have fewer cells and less production. The thymus also shrinks. So there's a drop in the thymosin production as well. And you'll know that your elderly people that you're caring for right now, they do get infections more easily. Their skin is more fragile. It's quite easy for them to succumb to an influenza outbreak. You may lose some of your residents to an influenza outbreak. We lose them every year, sadly. Yay, we're done. Okay, I'm going to set up the next 7 slides for respiratory. You guys can take a stretch or whatever you'd like to do.
So these two ladies will both be here next week.
Pardon me?
It's just me.
Oh, really?
Yeah.
Okay, I know that Joanne emailed me.
But you're great.
So what's the next week is okay, here and reproductive. All of them. Yeah. That's okay. You know what, Brenda? I will drive all the way up. Yeah. So it's your responsibility to take all the notes. There's nothing on it. Yeah. Oh, big responsibility. You guys can go Okay, let's go to the respiratory system. Okay, yeah, thanks, Joanne. Just gonna ask you, could you please close the door? It's getting lousy out there.
Very easy.
Okay, so on to the respiratory system. One of my favorite systems. I think it's cool. Yeah, whenever we have anybody coming in that we're doing a procedure for, as far as we do conscious sedation for people who dislocate their shoulder or whatever the dislocations and fractures. So we put them to sleep for a very short period. And I always do the airway management. I just like that part of it. So I like lungs and airways. So whenever we discuss who's doing what, I always say, oh, I'll do airway. That's good. I like that. Yeah, it is. Well, fortunately, with conscious sedation, usually people are breathing on their own, but you can never take the chance that they may stop. So yeah, we have to have everything prepared when we do that.
Hey, that was me.
Mm-hmm.
At the C-section. It was conscious.
That's right. Conscious sedation is awesome stuff. We use what we call Dazzle. I think it's used as a date rape drug to our countries. Yeah, because it is amnesic, right? You can't remember what happened. And we use that. We use.
How did they get a hold of that?
Pardon me?
How did people get a hold of that?
Black market, whatever on the street, it's available on the street drug. And it's really sad, but that's how it works. It does create amnesia. And so that's how they can use it as a drug.
Has that happened in Vancouver? That's what I left after that.
Oh my goodness, that's scary. Well, it's funny when we were in training, we'd go to clubs and stuff like that. One of the big things is at that time, LSD was more common. That people would put LSD into your drinks or whatever. And you'd always walk around with your hand on top of your drink. You'd never put it down. You would never leave. It never left your sight. And I remember one night I was up dancing and I had left a drink on the table. I just poured it out. I wasn't going to take a chance. But yeah, and that's what it is with Dazzle and Dazzle. That kind of thing. You just can't leave anything they're eating or drinking available to other people. Okay, we have a breathing lung here, which is really cool. Yeah, it is. And you can see how the diaphragm drops and the intercostal muscles expand. And it brings the air in. So the atmospheric pressure on the outside of the lungs is higher than the inside, right? So when you breathe, you have to use muscles to breathe in, to draw that. It's like create a vacuum and draw the air in, right? And so when you just relax, you don't have to push it out. It just relaxes out. That's because the atmospheric pressure on the outside is more than the inside. So it just comes out that way. But you have to work to get it in. This comes up a lot in emphysema, asthma, and those type of things. So we'll just carry on. Yes. I'm going to watch it breathe. Oh, carry on. Oh, here it is. There, okay. Some of these slides, like I say, are very busy. I don't want you to feel like you have to write everything down. You already know how to do this stuff, right, from your biology classes and stuff like that. So this is more of a review. So lungs provide a vast surface area for exchange of gases. And when you think of the alveoli, the little balloons in your lungs, I have nice pictures of those in here. I know you guys have seen them before. Oh, I have my- okay. So the alveoli, which are at the very terminal ends of all the bronchial tubes and the bronchioli. Again, they're just like little balloons, like little grapes. On the one side, you have your deoxygenated blood, and on the other side, you have your oxygenated blood. And the exchange occurs in the alveoli, right in the capillaries. That's where the exchange between oxygenated and deoxygenated occurs. They're a very important part of the lung system. Without their exchanging, of course, your lungs wouldn't work at all. So passageways, of course, are all your trachea, your bronchial tubes, your bronchioli that move the air in and out. Allows us to speak as well. The respiratory system includes the nose, the nasal cavities, the paranasal sinuses, and the pharynx. And this picture, unfortunately, didn't turn out very well. The tongue is here. The nasal pharynx is behind the nose and the back of the nose. Paranasal sinuses occur in the bony structure of the skull. The nasal cavity itself, and the oropharynx down there. So remembering these two is easy enough because nasal is nose, so the nasal pharynx is at the back of the nose area. The oropharynx is lower down, and that helps you remember that this one is the by the nose. They do warm and humidify the air when you breathe in, so it makes it much easier for your lower respiratory tract to move the air if it's got a moist surface. So the lower respiratory is the larynx or voice box. Now, remembering the difference between a larynx and a pharynx, the only way that I've ever been able to do that is larynx starts with L, la la la. That's the larynx, that's your voice box. Okay. But the pharynx, you know, the words are so similar sometimes. So the trachea is the large tube right at the top here, and you can see your trachea if you keep your head backwards a little bit. The bronchi are the larger vessels, which are here. So you've got your trachea is the first one here. Get it closer to them. Actually, they can't see much of this because it reflects the light. Oh dear. Anyways, the trachea, you've got your bronchioli that get smaller and smaller down to the alveoli. That's a better picture than the first one. Just differentiate the upper respiratory to the lower respiratory. Oftentimes you'll get people come into the emergency department and they have runny nose, they have a cough, you know, their ears are bothering them. So you put down upper respiratory infection. So it's whatever's in that area has infection. So you see URTI, upper respiratory tract infection, that you'll see on the top of the emergency form. So you'll know that that person is coming. And then it differentiates the lower here. So I talk about conducting structures and the nose all the way down to the terminal bronchioli. The mucosal membrane they're speaking of is a nice moist membrane that humidifies the air that comes in as well. So they're talking about the moisture, how it enters. And I'll just let you read through those because like they're fairly busy slides. I'll read them up to you. I'm not sure if there's another picture in here, but I think these little hair-like projections are called cilia. And the cilia actually produce mucus, and they move the mucus back up the respiratory tract to get rid of particles, dust and pollens and that type of thing. If there is a breakdown in the cilia, oftentimes you'll get more commonly pneumonias because the mucus isn't being pushed out. And people who smoke burn those off. So they don't have this efficient mucus production, and they don't have as efficient clearing of all the debris out of the lungs. Smoking does a lot of damage to those and to other areas in your lungs. Now this lamina propria, layer of connective tissue underneath the respiratory epithelium in the upper respiratory tract. Contains mucus glands, and the mucus, of course, keeps everything moist. And the mucus also traps pathogens, it traps pollens and debris, and it helps, like those little cilia help to move it up and get it out of the lungs. The respiratory defense system, the air filtration, the goblet cells, they produce like a mucus gland, and the same thing again, it produces the mucus that traps the debris. The cilia that I was talking about when I showed you in the picture, that sweep upwards, remove a lot of debris out of it. Mucus production increases with exposure to certain stimuli. Well, stimuli would be like an infectious process, right? If you have a cold, of course, you're always coughing stuff up out of your lungs. And also, if you have allergies, oftentimes it makes more mucus be produced. There's a sort of a second line of defense down here. Once you produce the mucus, anything that escapes it, there's macrophages available in the alveoli that will help get rid of the bacteria or whatever. The macrophages that once they're released, not the last phase. I think you're right, but I can't. I would have to look that up too. But I think you're right, because they do send out a signal to produce more macrophages. But I'll have to look at that. So I talk about the nasal mucosa, and of course, when you're breathing in, that's the nasal sinuses. That's their job, really, to warm and heat, and also to moisten. But also, they capture a lot of dust particles. So that is your. Epistaxis, you're going to see this word a lot when you're in training, and also when you're out working. It's just a nosebleed. It's nothing more than that. As we saw, the nasal cavities, when we looked at the photographs before, they are really have a lot of vascularity to them, which makes a lot of sense because they are used for as well. So the nasal turbinates are very vascular for that reason. They are used for, I'm trying to find a picture here. We have a good picture of that. So any of these causes, of course, can cause you to have nosebleeds. Drying is a big one, especially in the wintertime when you're heating your houses. It usually gets really dry and nosebleeds can happen. People can actually really lose a lot of blood through a nosebleed. It's quite amazing how much they can lose. So when people come into the emergency department and they're having nosebleeds, oftentimes we'll do a hemoglobin to see how much blood they've lost. Because they've usually been bleeding a lot at home before they come to see us. We're the last resort, so they may have lost quite a bit of blood. So we'll do a hemoglobin and see what their red cell count is. The nasal pharynx is at the back of the nasal cavity. And it contains pharyngeal tonsil-like tissue, so your lymph tissue is back in there. So when they take out your tonsils, usually they go back in and they take out the adenoids as well. They take them both out. Because usually they're both infected to the point where they can't recover. So they'll clean out this area in here, and they'll also take the tonsils out of there. Oh, the little thing that hangs down, the little thing you can see at the back? That's a uvula. I was wondering what that was. That's what it's called.
What's the purpose of it?
It's more of a sensation. So food or anything kind of going, it tells your throat, your glottis, which closes over your windpipe. Kind of tells that the food is coming. And you better close up, because if you don't, there's going to be food in the lungs. So it's more of a sensory type thing. I saw a little guy came in one day, and he'd been running with a popsicle in his mouth, and he pushed the popsicle stick, cut the uvula right off. Oh, she's closing her ears. Yeah, he just off it. Anyway. But yeah, so that's why you tell your kids don't run around with sticks in their mouths. That's yeah, or run with that.
So in that case, what do you guys do?
Nothing. There's nothing they could do. No, it was very partially, like this is the TV vet, so we just kind of, because you can't really reattach it. So, yeah, wasn't good. The oropharynx is the middle pharynx and lies between the soft palate and the soft palate. You can run your tongue to the back of your mouth, and you can feel the soft palate. And the hard palate is in the front. Right? Feel that. So the laryngopharynx, most inferior pharynx, between the hyoid and the entrance to the larynx and the esophagus. So the hyoid bone, remember where the hyoid bone is right about here? So it's down there, the laryngopharynx. When we intubate somebody, we use a laryngoscope. So you're in that area, you're down here. So I don't know if you'll ever get involved in helping doctors put a laryngoscope down, because you do put them down to intubate people, usually during cardiac arrest. So you may be asked to put pressure on the hyoid down, so the doctor can get the scope through. It opens up, helps open up the vocal cords for them. The larynx, inferior to the laryngopharynx. I think if you guys are studying this, just get out a diagram and look at the diagram. because trying to learn it this way in a written form is very difficult. So just get a good diagram out of your textbook and just have a look. So the vocal folds are located at the entrance of the glottis. I have pictures here of that. I wish they were bigger. I think I have a larger one. Just let me find it.
Is there a reason as to why women don't have comments?
Yeah, we don't actually. We don't have that, but I don't know why. Unless it's hormonal. I wouldn't even think about it. That it's more prominent in men. I'm not sure. That's a good question. We have a lot of good questions today. You're going to have to get an award for the best questions today. Okay, now this is a very good. What's that? What is my favorite? Oh yeah, there's an antibiotic called moxifloxacillin. I don't know, I just like that. Moxifloxacillin. I don't even know what that means. That's a good one. Anyways, I'm sorry. Back to the pictures. So here you can see on, I wish I could hold this book better. Try it like that. There we go. It's got a delay on it. It takes for a while to get it right. So you can see the vocal cords on this side here, right there. So if you were to take a laryngoscope and you put it through, what you would be looking at is that little slit, the vocal cords. Right here is the hyoid bone and the epiglottis. The reason the epiglottis is so important is it does stop food from going down into your lungs, right? There's also a disease, a swelling of the epiglottis is called epiglottitis. I don't think it's no, it's not. But you'll learn more about that in your nursing part. Epiglottitis is really critical for children. If you have a child coming in with an inflammation of the epiglottis, and if it's inflamed enough, it's going to block their breathing. So if you have a little type come in who is having respiratory distress, and they're leaning forward on the stretcher, and they're drooling out their mouth, you better get a doctor there. Because that kid could actually obstruct and then not be able to. That is considered a did he have a penny? Oh, and it's blocked. Yeah, it is blocked. It got stuck there. The good part about pennies, though, they can turn. So you can still get some air through there.
They have to get into the hospital.
Yeah.
Now he was running with the penny in his mouth.
Right. See that? Running with sticks, running with pennies, it should be. But what amazes me with children is that they actually have people because they survive their childhood. I always, when I was in training, of course, I worked in emergency part of my training, and parents would come in with their kids, you know, they've broken this or done this or hurt themselves, and I would think, such bad parents, they're just awful, they're not caring for their children. And then I had my own kids and found out what it was all about. My little guy, when those walkers were popular, they're not popular anymore, we're not supposed to use them anymore, but at the time they were popular and it was funny. He was out on the deck, kind of running around, and that your mother's, you know, sense went off. But, okay, I haven't heard of him. What's going on? And something's not right. So I go up there, and he has taken my strings to my curtains that were on the outside. I had blinds that came down, and he wrapped them around his neck. And so he was just like this, hanging himself. And I was like, my God, every moment, guys are doing something crazy. Like another guy rode his tractor off the stairs. He was just riding around and just straight over the stairs. I mean, why would you do that?
There's a bubble machine, so you had to
Yeah.
always go outside and she'd
Oh,
go
yes.
after right downstairs.
Yeah,
And
I
she
know.
like rolled.
Yeah.
And she was like,
And before, like I say, when I worked the emergency as a student who never had children, I used to think those parents were horrible.
yeah.
And now at this age, I'm thinking, I'm surprised there's any humans in this world
Yeah.
because they survived past age 2. That's amazing. But epiglottitis is something that you get in kids who've had an upper respiratory tract infection, and then that epiglottis inflames, and then it blocks the airway. It's very serious, and there's not. You will have to do a trach with that child to get them to. You have to go below the epiglottis to get some air into that. So anyway, let's grab that. So sound production is as air passes over the glottis to cause vibrations in the vocal cords. And sometimes you can get laryngitis, right? Can't speak. Well, that's just inflammation of the vocal cords. They can't vibrate anymore. So I used to love getting laryngitis when I was working at the hospital because you weren't really sick and you didn't have a cold, but you couldn't talk. So you could go home because you couldn't get anybody. That worked for me. So high pitch, they're just saying that tense vocal cords and low pitch is relaxed. And that makes sense with people who are stressed, right? When you listen to them yelling, their voices are pretty high if they're upset and yelling. But when they relax, their voices drop down a bit.
I have a question.
Yes.
Why is it when people that are drug users, their voices change?
What is that? So when
Or drug users music, like drug vibes and voices change, like they don't sound the same as they do when they're talking.
So what type of drugs are they using? Are they using cocaine? Because cocaine is usually inhaled, right? Sinuses, and that could affect the upper respiratory tract, just the drug itself. But you're sort of thinking as their health declines, and they get sick, their voice changes.
Like they have some girls who feel they have a higher pitch.
Right.
Probably jumping stress.
Yeah, it could be. It could be a stress, the stress level, or it could be the damage the drug has done itself. I know you'll get people who use a lot of cocaine who are constantly have sinusitis because it's damaged the sinuses, and they're coughing and they're hoarse because of the damage that the drug itself did. But it can be otherwise. It's just they're just not well. I know it's, like you get people. You can talk to a friend on the phone who's not feeling well, and just with the pitch of their voice, you know how well they're feeling. My aunt has cancer, and I phoned up and chatted to her the other day, and you can tell that she was ill just by the tones and changes in the tones of her voice. And then I phoned her. I was talking to her the other day, which is a couple of weeks later, and she could tell she was feeling so much better just by the level of her voice, the pitch it was at. So I think it's a lot to do with emotion. So, all these structures are involved with speech. Like your tongue, lips, and cheeks are usually probably ones that you forget about, right? My lips aren't working on today. People who have hair lips or they have had problems with the top of their mouth, you can tell they have definitely a distinct sound to their voice because of the fact that their lips and their palate has been affected by a cleavage in the palate. So that would make a difference too. So all those structures are involved in speech.
My cousin is taking it from holding it up, how she can make herself sound traditional. It's all these different sounds that she can make up. I think never doing any of the voices.
So we're talking about the trachea now. The first part up here, the really thick area here. And it's about 2.5 centimeters in diameter. And I've got a few these are little examples of tracheas. I just made them myself. I don't know if anybody will recognize what these are. Do you know what these tubes are? Anybody rides a motorcycle? They're actually the covering that you put on the wiring They're wiring covers. That's what they are. My son had them. He was repairing his motorcycle. And I'm going, oh, those look like little tracheas. Look at all those little tracheas, right? So they actually are perfect, right, because of the size. This is an infant one, just the size. This would be 1-year-old to 2-year-old, about that size. Your child 3 to 10, and this is an adult. This is a small adult size because usually adult sizes are a bit bigger than that. But you can, when you look at these, there's my people at home here. To get up here. These are just little tracheas. So when you look at the size of these tracheas, there we go. With the infant, I mean, it's just teeny, and I'll hand these around. You can understand just an upper respiratory infection, a bad cough that's producing a lot of mucus. These kids can be obstructed with mucus, right? Just mucus will do that. You look at this 1-year-old to 2-year-old. Those are the peanut ones, right? They'll get peanuts stuck in their tracheas and they can't breathe. Your little person with your penny. How old was he when he got a penny? About 5. So he's sort of in this area here. And even when you look at the size of that, you can see how a penny's going to obstruct that. It's going to be right over top of it. There's no way he would be able to breathe. The good part about some aspirations, and you'll get aspirations a lot in elderly because the epiglottis isn't functioning as well as it used to. It's weakened and sometimes it partially closes and it allows little bits of food. So you get aspiration of food particles, so you'll get aspiration pneumonias. That happens frequently in the elderly. Same thing, it's just that the muscles are weakening with age and the epiglottis isn't functioning as well. Or it is from minor strokes. Strokes will do that too. That just doesn't close properly anymore. So I'm going to hand this around and let you guys look at the size of these. Just take my little cord with me today. But it helps you to just visualize. It helps you to visualize how come people start coughing when they have obstructions and things like that. So you all took CPR to take this course, right? So you can see why you're not pounding people's backs when they have things stuck in there. It's not really helpful if you're pushing them down.
When I just did my CPR in August, and he actually said that you do now. You do. Yeah.
And I actually don't understand that, to tell you the truth, because if you have an obstruction and you're banging on somebody's back and they are vertical, you're not going to help them kick it out unless you're doing a Heimlich, because that's using the air in your lung to push it out. Yeah. But if you're just banging without using the air in your lung to push it out, I don't understand how that's helpful.
Because, like, theoretically, you're just kind of pushing it down, right?
Yeah, yeah. You maybe, and maybe that's what the theory is, you're pushing it to a position where the person can still breathe, but it hasn't gone up, it's come down. So that might be what they're saying. I'm not sure why they've gone to that, but you're right, they have gone to that, and that is new this year. There wasn't in the course last year.
What do you do?
Yeah. What are you talking about?
Because I think about it last year too, and it was back on their back. No.
Well, there was always when you're administering back goes to a child, and the child is their face is facing the ground so that they're at this angle. Yeah. So that would definitely dislodge anything that's in their windpipe. But I'm not really understanding being upright and banging on the back. But to me, that would just, gravity would pull it down. Unless it's just moving it. That's the only thing I can think of. It's moving the obstruction. It hasn't got rid of it, but it moved it enough to get some air in. That's the only thing.
That was so weird.
Yeah. Yeah, why are you doing that? Yeah. They change things every year just to make things, which I think is rather funny because, I mean, I trained years ago, and now we've gone back to the same amount of ventilations that we did like 30 years ago. And I'm going, oh, it's just recycling same old stuff, right? Yeah. So just to bring this to your attention, not that you have to remember it, but you might think about it, is the start. It starts at level C6 and T5. So anything that's going to damage that area, if you're in a car accident, you have this damage, you may do damage, breathing as well for the innervation of those areas. It branches into the left and right bronchi, the main bronchi. The bronchi is straighter than the other, and I believe it's the right one. I'm absolutely sure before I make that statement. It's the right main bronchi that things get lodged into the straighter one. Yeah, the right one. So you can see in this diagram that there's one that's quite curved. I really have to concentrate to get this right. It's good practice. There, okay. The book is so heavy I can't move it after this. So this goes into the right lung. It's much shorter and straighter. And oftentimes if you have debris going down there, if the child has swallowed a peanut or something, it'll go into the right side always because it's an easier tract to go down. Oh, I think that's pretty good for that. Talk about the tracheal cartilages. Cartilages that are kind of like shaped like a C. It adds stiffness, but without the cartilage in the back of the C, it adds flexibility and it can dilate. We talk about large chunks of food going through the esophagus. So as the food pushes forward, the trachea can flex a little bit to allow it to go by. We're back to our neural again. Sympathetic activation increases tracheal diameter, allowing greater volume of air to move in and out. So your sympathetic is your flight, fight or flight. So you would want to open up your airways so you get a lot of oxygen before you start running. Okay. I don't know whether all this stuff really is making a difference. Yeah, let's try. It doesn't like it. What's that? I said my terminal wires. Maybe. No, it works then. I've got to stand here. That's all right. Okay, we're here now. Okay. So the lungs located in the pleural cavities. That's easy. They extend just above the first rib, so just up in here, the apex. Right in there. Okay. And they're divided into lobes. The right has 3 lobes, and the left has 2. And the reason for that is the left lung is smaller, just because the heart is there and it has to accommodate the heart. I'll leave that up for a second so you guys can write down what information you'd like, and I'll have a drink. Right down, it's getting cool in here. Yeah.
Does it go 6, 5?
What are you thinking?
Like for the triangle?
Yes.
Yeah. Triangle and right back.
Right. So you've got a. Can you see it in the pictures that I handed you out?
Kind of like
I've got it written down here somewhere. Just a sec. Let me look it up. It's either in that or Danielle. Have a look in that anatomy, the assessment book, and go to the lung part, and I believe it's in there. It'll tell you exactly which level it's at. Is it there? So do you want to explain it to the people in the class? Now that you asked the question, you have to explain the question. All right.
Because there's, this is your back. So your one lobe, it's the fourth rib, the fifth rib, and then the sixth. So you can just always remember that it makes that triangle. And then it's easier to remember where those lobes are located.
Great. Right. We have no idea where to look to listen. And the thing is, like I was telling Danielle earlier, she was just talking to the students at home. She was asking about the anterior surface of the lung. Where would you listen to it to get the lower, middle, and upper part of the lung? So it is a triangle that you're listening into. The only problem is with that, you can do it with men, but you can't do it with women because of the breast. Usually breast tissue obstructs you listening to that area. And before class, Danielle and I were talking about nurses. We don't often listen to that area. Doctors would be, or spirologists actually will listen. Even your general GPs, if you go into the cold or cough, they'll listen to that. And then they listen to the apexes up here. You can't really hear those very well. But it's, it's a good idea to know where they're located at some time if you want to. Good. Okay. So this is just a picture where it does show you in this one the upper lobe on the right side of the lung, middle and lower lobe. And then the left lung itself has the lower lobe, upper lobe here, but there's no middle lobe. So when you're in your nursing practice, when you're listening to lungs, you will not be able to listen to the middle lobe on the back, because all you get on the back, and that's, I've given a, do you have to go to work? Oh, sorry. The lower lobe actually extends from here to here in the back of the lung. And that's what you listen to. So when you're writing it down in your nurse's notes, what you heard, you're always referring to the lower lobe. And a lot of times you'll see people write middle lobe, but they can't hear that. So they just didn't listen in anatomy class. So take care. Have a good shift. We'll see. So you're away next week? As well? Oh no. No. Well, do whatever you'd like to do. Well, nice up to you. Okay. That's okay. This isn't a prison. No. Okay. So alveoli wall, they're very elastic and they recoil. So you've got those little balloons that we looked at earlier. They look like little grapes, balloon-like. They contain type 1 squamous epithelial. You don't really have to worry too much about that. But it's just that it's a very thin layer and it allows oxygen and carbon dioxide to cross over easily. The alveolar macrophages, they have their own so that they can help keep infections out of the alveoli. This is important. The type 2 septal cell produces surfactant. Surfactant is very important with babies. If babies are born premature and they don't have surfactant in their lungs, it makes it very hard for the alveoli to expand. They kind of stick together. They're sticky and they're stiff without the surfactant. So oftentimes they can give the baby surfactant, or they will give the mother medications to help the surfactant be produced and helps the maturity of the baby speed up a little bit if the baby's imminently going to be born. So I'll just let you write down that because I'm sure you'll be seeing that again. You know this from your first baby? Did you have problems with the surfactant? Like it was no breathing problems. All good. He was born with 36. 37. But it was not too bad. It's not. How much did you weigh?
She weighed 5'12".
Oh yeah. That's a nice little baby.
Yeah.
I'm saying he. You knew it was a girl. I was going to say.
Yeah. Nobody ever older.
Is that right? Oh, they're
Yeah.
so sweet and they're little tiny. I love them.
Even then, when the rest of the food that is like nothing about them.
So there's just a picture of the alveoli. Again, they look like little grapes, and you can see the capillaries on the outside, the exchange of the oxygen and carbon dioxide in the blood.
Oh, we did have to stay home for a week.
Mm-hmm. Yeah. Oh, yeah. She lose weight.
Yeah, she lost over.
Oh yeah, yeah. That and they do normally lose some weight from fluid and just passing zirconium and stuff. They lose weight. Oh, exciting! Can I wait till the baby's born?
Yeah.
I'll have to go in and find out.
Yeah.
Oh. Okay. Anyway, so people at home wonder what we're talking about. Jillian's going to have a baby. That's what we're talking about. Okay. Let's enter the lungs from the pulmonary arteries and leaving the right ventricle. And we talked about the circulation of the heart. Each pulmonary artery branches into an arteriole, and the capillaries surround each alveoli in the respiratory membrane. And then we have the circuit, right? So the pulmonary veins that drain back into the left atrium. And I don't know if you remember much from cutting our cow's heart open. Yes, last time we were here. Seeing the pulmonary veins coming back into the atrium?
Yeah.
Yeah, you guys got your fingers in there. Saw it. So that was kind of neat. Okay. Pulmonary embolism, you'll hear a lot about this in your practice, and what it is that a blood clot actually goes into the heart, not the heart, sorry, into the lungs. So it can be caused, the blood clots can be caused from deep vein thrombosis in the legs, from sitting for long periods of time, and then a clot forms in the legs. And then a little piece breaks off, and once it breaks off, it's called an emboli. And it travels up into the lungs and obstructs the oxygen capacity of the alveoli because it's a clot there now. Having a pulmonary embolism can result in congestive heart failure because you have now blocked the blood supply. And so that may also happen. But mostly what you get with pulmonary embolisms are a lot of chest pain, and they'll present to you as almost a cardiac problem. You wonder why this person's having so much chest pain. Do an x-ray on them and you'll see the clot in the lung. And whatever, depending where the clot lands, anything past that clot will just collapse and you'll have a blackened area where it's collapsed. The pleural cavities, separated by the mediastinum, and that's just, the mediastinum is the central portion right here. And each pleural sac see it right here. Diaphragm is here. Then you have the pleura on the outside here. This is where you get diseases like pleurisy, when the pleura itself, there's fluid between the pleura and the lung, and this is pleurisy type thing, and forces the lung to collapse from the outside pressure. The pleural fluid itself is just like synovial fluid or nasal fluid. It provides movement and lubrication. Thoracentesis, and we talked about fluid that got between in this pleural sac. And all they do is they freeze the outside before they start doing this. They put some freezing in the chest wall, and they'll just take a long wide bore needle, and they'll just aspirate, take some of that fluid out to relieve the pressure on the lung, not collapsing the lung. So the difference of this between pulmonary edema is in the lung itself, right? This is on the outside of the lung. So that's what the difference is. It's in that kind of that pleural sac that's on the outside of the lung. It would be wise to write these down because hypoxia you're going to see a lot. Anoxia you'll see a lot in your practice as well. And these words here too. So you can actually, if you don't want to write down the whole thing, you can just write down just the words and you can look it up later. Or if you'd like me to do it for you, you can write it down now. Probably easier for you to write it down. But these words you will hear often.
If we just review some of these in our class,
yeah. Okay. Well, if you have it, you don't have to write them down.
I'm sure I have it from here, so I know that I can do that.
Okay. If you've got it from another class, that's fine. And I probably, if I do the keyword studies, I would include those words. Hypoxia, anoxia for sure. Anoxic just means the person is completely starved of oxygen. The IC on the end just means that the person is that. It refers to the person, and the other words refers to what is happening. I'm not really sure if the students that are online are taking a nursing course, or I don't know where they're at in the nursing course. I'm not sure if they have the same information as you guys do. Pulmonary ventilation. We saw that at the very beginning of this some PowerPoints, where the diaphragm moves down, the ribs move outwards, and the lungs inflate just by that movement. And we talked about the atmospheric pressure being greater than the inside pressure. Okay, so I think we've kind of done that one already. This also talks about atmospheric pressure and the pressure on the inside. So we've actually discussed that as well. Let's have a quick look at it. Compliance. Compliance is just how easily the lungs expand or how more difficult they expand. And you especially see this with emphysema. With emphysema, actually, it's not that they can't get the air in, but they can't get it back out again. Because of the loss of elasticity very difficult for them to get that air out. It's the same type of thing that happens with asthma. Asthmatic people can get the air in, but because the bronchial tubes and bronchioles are blocked with mucus, they can't get the air back out again. Surfactant, which makes the alveoli nice and pliable and stretchy. If there's a lack of it, of course, they're not going to be as flexible as they used to be, not as compliant. You'll see a lot of your elderly, for some reason in men you really see it, in women you don't see it as much, as they have a barrel chest. They keep breathing in, but they can't get it back out. And after years and years of that, their chest remains circular and barrel-like. With age, the skeletal movement is less. It gets tighter, as the muscles become less flexible, and it won't move as well. Cystic fibrosis, and I thought this was really interesting because it's a hereditary disorder affecting Caucasians. Doesn't seem to be in the other populations, so that's quite interesting. Kind of a sad disease. The body itself produces very, very thick and sticky mucus. Very hard for these young children to breathe, and also affects the pancreas and it affects the guts as well. So they usually end up taking a whole bunch of medications to help them digest their food, and then they take medications to help liquefy the sticky mucus. A lot of physiotherapy for these children. We end up doing a lot of postural drainage and physio on their chest to help loosen this mucus so they can cough it out. And unfortunately, very expensive disease to have because they do a lot of inhalations of medication. Hard for the parents to raise these little people. The percentage of the gain is really not for you to memorize. It's just to give you an idea of how much energy we expend just breathing every day. So as the compliance declines, as all of those areas stiffen up and it's more difficult to breathe, that's why your patients with emphysema are tired, because really they're spending a lot of their energy just breathing. Hard for them. The muscles involved in the diaphragm. Of course, know where that is, right in here. And the esophagus goes like through the diaphragm into your stomach, right? So there's a hole where the esophagus comes out. But it's nicely sealed, so the diaphragm can move up and down without any leakage. There are some diseases where there's holes in the diaphragm, and when you go through the nursing program, so learn all of that. And of course, as soon as there's a hole in the diaphragm, it affects respiration. You can't breathe as well. These are all your muscles involved, and I would that's nice to know, but you don't need to know. So that's like way off the top. And just to give you some pictures of the different muscles involved, where the diaphragm is located, and all these intercostal muscles. Intercostal, meaning in between the ribs. You'll talk about that in your nursing program when you talk about children who are having problems breathing. They have intercostal in the drawing, right? You'll see the ribs as they breathe in. You actually see the ribs because they're working so hard to breathe in. You'll see that. You'll see a tracheal tug right here with little ones that are having trouble breathing. And you see the substernal in drawing as well. And that's how you can tell that they are having problems breathing and should probably go to the emergency doctor. So let's just review what we've already chatted about. This word, eupnea, normal breathing, right? It's just your normal, everyday, quiet breathing. And it just describes what happens, and we just talked a little bit about that. Your deep breathing is when you use your diaphragm more. Shallow breathing is constant breathing. These muscles you're using, and usually shallow breathing is more up in the apex. You don't get the air down into the bases of your lungs. Women are accused of this. Naturally, we tend to shallow breathe and use the upper portion of our lungs. We should be trying to expand our lungs more and provide more oxygen for ourselves. I don't know why we breathe like that. Women are notorious for just using the tops of their lungs. I showed the nurses at the hospital that word. You know, a lot of us have been on a training for a long time. I said, "What's this mean?" I don't know. So don't feel bad if you didn't know that. No. I thought it was rather funny, actually. Cool. Yeah. Hyper, of course, whenever you see hyper, it's fast, right? So hyper is going to be, involves all the muscles, and it's forced breathing, and it's like you've been jogging for a while. Hyperventilating is more like a panic breathing where you're like you're scared, right? This is just an exercise of your breathing. You've been out running and you're breathing heavily and quickly. So that's
Or after some good action.
yeah, oh dear. Yes. I was over. Come on. Why this thing? Okay. So, well, when you see hyper, then hypo is going to be the opposite, right? Yeah, you're just going to be breathing slowly and relaxed and not breathing too much. Okay. Respiratory rate, the normal adult is 12 to 18, and that's something you need to know for reasons that I can't explain. And you'll have to use it throughout your career. You're always going to need to know what the normal is for breathing. The normal rate in children is 18 to 20. This is really dependent on the age of the child, but your infants are in the 30s. So your babies, infants are in the 30s. So this is more like, say, 4, 5, 6-year-old, an older child, not a baby, not an infant. You'll need to know this if you work in respiratory, because these kids that come in who are having trouble breathing, they can have a respiratory rate, in the 30s, or 35, and that's really quite fast. So you have to know the normal so that you can determine how distressed they are. Reserve volume, the amount of air left in the lungs that you're able to expel after your normal expiration. So that would be forcing it, right? You have to use your intercostals and your diaphragm to push it up to get it out. The average reserve volume is about 1,000 ml. Now I brought with me 2-liter bottle, right? So there's 2,000 in there, so it's about half of that. That's about as much as your lungs hold. About 2 liters. That's much. You got this on this side and that on that side. You got 4.
Yeah.
It's quite a lot, yeah. And of course, it depends. It's size dependent too. If you're a small female, it'll be a lot less. Yeah. A large male is going to have a greater lung capacity. That's just logical. The residual volume is the amount of air left in the lungs even after forced expiration. So you've got everything out of there, and there's still air in there. Because you have to keep those alveoli expanded. You can't collapse them completely. So they still will have some air in them. So you can just kind of just worry about these 2 lines and none of that. You can just read that. Plasma. It has a limited ability to carry oxygen because you guys already know that your red blood cells are carrying oxygen. So do you remember what in the red blood cells carries the oxygen? Carries it. Hemoglobin. Yeah. Hemoglobin. Yeah. And you'll like that's definitely something you'll have to remember. The heme part of it. It has iron. Okay. Good. Okay. There we go. We're back to hemoglobin. So we have studied with our blood system. We studied hemoglobin. There isn't more on here that you would have you already done. Homeostasis, it's just keeping everything balanced, right? The change, if the O2 is low, of course you're going to increase your respiration to get your O2 up to the balanced level. Talks a lot about partial pressures and so forth. Fortunately, we're not going to get into that too much. This is just more for your information only. So let's read it. And it's very logical. I mean, more blood volume, the more oxygen you're going to have. That's just plain logic. The medulla oblongata, the brainstem, contains your respiratory regulating center, cells. And when we studied the brain, we didn't talk about that, but it's just a reminder to you that we're that. So in a way, it's kind of interesting that we can build on what we've already done. We learned it all. Yeah. The pons, again, another part of the brain that we studied already, contains inspiration and expiration. Look at with that brain centers, and it adjusts the rate and depth depending on the stimuli. So, if you were running, of course, it would increase your depth and increase your rate. But the pons is responsible for that. Again, it's kind of a review, again, with the chemoreceptors and the baroreceptors. Baroreceptors were responsible for what else? Remember? Blood pressure. Thank you. Yes. Okay. I've seen those before. Actually, it's good, in a way, it's a good study review. We're getting close to the finals. So it's kind of nice to repeat some of this. The other term, apnea, I think it was in the first one. Cessation of breathing, yes, it was. And hyperventilation. Hypocapnia, a low CO2 level. You see this you'll hear about it in emphysema, right? When LPNs are not allowed to give more than 4 liters of O2, that's your maximum. Because a lot of people with emphysema, if you give them more than 2 to 3 liters, they lose their ability to detect carbon dioxide in their system, and they won't take a breath. So you actually slow their breathing by giving them too much oxygen. So that's a rebounding thing, but it happens in emphysema.
More than they're used to.
What do you mean?
More than they're used to, it'd be more oxygen than their bodies.
Well, carbon dioxide is your trigger to take a breath, right? Once your carbon dioxide level reaches a higher level, then you mentally will take a breath but with the COPD people, they don't register, the COPD meaning emphysema and chronic obstructive lung diseases, they don't recognize their don't let their CO2 level raise quite significantly. Yeah. You give them too much oxygen. They won't take a breath because they haven't got the CO2 stimulation to take a breath because you've given them oxygen. Yeah. And they don't breathe in. So, but you, like I say, you'll learn about that further in your nursing program. Aging in the respiratory system, we've already sort of talked about that. We've talked about the decreased elasticity of the muscles. Even with the diaphragm, the elasticity changes. Arthritic joints in the costal area in the rib cage is going to be painful and uncomfortable to take deep breaths. So that's not going to help in exercise, that's for sure. It's going to be. And emphysema is very common, or the chronic obstructive lung. And I think that oh my gosh. Oh, this is really important. You're going to see this again. I did this one. It's post-operative deep breathing and coughing when you're training the patients to do deep breathing and coughing. It's usually taught before surgery in the pre-operative clinics. If it's an elective surgery, they'll go into their pre-operative clinics and they'll have their training down there, and they'll teach them how to move their legs and their ankles and their knees and so forth to make sure they don't get clots in their lower legs, but also they will teach them deep breathing and coughing. So taking a deep breath just encourages the alveoli to expand to their full capacity and also provides more oxygen, right? If you've got a nice alveoli nicely expanded, they're going to get more oxygen. It prevents pneumonia because the mucus doesn't pool at the bottom of the lungs. Atelectasis is when the lung actually collapses. So it would, like the alveoli would collapse and stick together if they got atelectasis. It assists in moving the mucus up to the pharynx to be expectorated. So that's why deep breathing and coughing is so important after surgery. Or with even your elderly people, you know, if they have had pneumonia, it's a good idea to encourage them to deep breathe and cough after pneumonia. Gets rid of some of those blockages that are in the lungs. And I do believe that that's the last slide. Jill's just about done. So that's the last slide for the students that are at home today. We are probably just going to be discussing reviews and that type of thing, and maybe some test stuff. If you're okay with that, I will turn to feed. Thanks, Alice, and thanks, Amy, for coming today. And we'll see you next week.
Thank you. See you around.
Yeah, thank you.
All right, have a good weekend, you guys.
Thank you. Can I ask you if the audio was better today with this mic?
Yeah, it was good.
Okay, great. Thanks. I should have got one. I should have bought one sooner. Thank you guys.
Yeah, thank you.
Take care.
Bye-bye.
Bye.